Now's the opportunity to ask questions, and I see we're getting some already. What are some of the overall roadblocks that you faced in getting this protocol, especially the PCT protocol, implemented at your hospital?
I think the rollout is, how you do the rollout is imperative. I have learned a few lessons. Honestly, with 10 years of critical care performance improvement and 27 years at the bedside, I could write a 1,000-page book on how not to do critical care performance improvement. One of my lessons that I learned with PCT is the devil is in the details. And it's very important that your physicians and nursing staff across the hospital understand what a PCT means. In other words, what do those low levels mean and what do the high levels mean for a patient on med-surg that was called for a rapid response and they have a level of 2.5. Does that patient have to go to ICU? Absolutely not. Do you have to look at the current therapy that that patient's on and utilize that PCT to ensure that our diagnosis is proper? Absolutely. The high and low number doesn't necessarily dictate our therapy. It's one piece of the puzzle. And so I think I could have done a better job at rolling PCT out in terms of the details of what it means to have a high and low number and what are the caveats, the trauma, the post-surgical patient, and understanding that it does go down quickly, but that those levels can be up in that first day. Another thing is that before we rolled it out, we had to ensure that our lab test was an accurate lab test here at this hospital. So what we did was we took 20 patients, just aimlessly picked 20 patients. And actually, when I say aimless, I think we had 10 that were infected and 10 that were not. We did their PCTs, and we actually sent out that same blood to a hospital in our state that we knew was actively doing PCTs to ensure that our levels were of quality in terms of the number itself. And that testing out phase did show positive. We actually had, out of 20, all 20 had a correlation to bacteremia. So in terms of those 20 patients, the negative PCTs had negative blood cultures and the positive PCTs had positive blood cultures. And when we tested against the other facility, it actually, our levels were the same as their facility. So that quality check turned out to be useful and helpful for us.
Brandon, do we have any audio questions?
Yes, we do. Please go ahead.
This isn't a question, it's a statement. We found here at our hospital that when you said, I think you said you had some that the negative PCT gave you a negative blood culture and a positive PCT gave you a positive blood culture, but you had some that didn't totally agree. We have found that if the blood culture vials were not filled adequately, i.e. underfilled, we had the potential to report out a negative when really if it had been filled correctly, it would have been positive. So that's one thing. Another thing that we are monitoring here now is that the blood culture vials are adequately filled.
Oh, what an excellent point. And I agree. Working at the bedside, one time I did have a lab tech say, oh, we don't need that much. And I thought, you know, these are important. These are hugely important to guide very potent antibiotics, and we don't want to give one dose of antibiotic that is not required due to our huge future issues with C. diff colitis and our sensitivity patterns going down. So that's certainly an interesting point, and I'll bring that up with my lab to find out what our standard is. What is your hospital recommending in terms of volume of blood going into your blood cultures?
We use Bacti-Alert, and it's clearly marked on the vial where you have to, the liquid comes to a certain level. When you put the blood in, it has to reach this level. There's a minimum and a maximum on there, and you have to hit the minimum or the collection isn't sufficient.
Well, that's interesting, and I will certainly take that back. I will also tell you I was involved with the Project Impact database, and I got to look at the comparative national data, and we did collect the data on whether our sepsis patients have positive blood cultures. And nationally, it was fairly low. It was about 40% nationally. And I had ICU data and CCU data, and I had like 15 and 30,000 patients in those databases at any one time. So I think that this is a national problem, but certainly a point that is well taken, and I'll take that back at my facility.
I've got a written question here. How helpful are molecular assays for blood culture identification of specific pathogens?
I think you're asking above my expertise level. I would like to say that I would love to answer that, but if you'd like to call up and we can have a nice dialogue to be more specific on that.
Okay. Any other audio questions?
Yes, please go ahead.
This isn't necessarily related to PCT. I work at Holy Cross Hospital in Fort Lauderdale. I'm the advanced practice nurse of critical care. And what we're struggling with is the implementation of the sepsis bundle, is identifying necessarily those patients. And what we're finding is they may not meet the sepsis bundle initially, but they'll still code out as a septicemia or a severe sepsis, but not necessarily be in septic shock. So how do you treat those patients?
Well, I do not mandate the central line and CVP monitoring unless the patients are on pressors.
Mm-hmm.
So we have to have 2 Forster's criteria and assumed or known infection. If their lactate is over 4, they go to ICU at my hospital.
Yeah, they do, yeah.
Yeah, and a lot of them, if they're not on pressors, they do not get central lines. I will tell you, I've done this since 2004, 2 facilities, and I've consulted with over 30 facilities nationally, and I speak to people nationally all the time just through my network of sepsis nurses, and I allow a Plan B PICC line for central line monitoring for our 16-year-olds and our 95-year-olds that don't want a big central line, because I'm all about individualizing care at the bedside. I think PCT has helped us with that diagnosis. The worst case scenario is when they think that they're CHF because they have a BNP. We know sepsis has positive BNP. Then they get Lasix and go off to the telemetry unit, and on day 2 go to ICU with proning and CRRT and Tigris. And, you know, that's our $1 million patient who ends up dying at the 3rd week level. And that's just a simple PCT really helps to distinguish. It's another piece of the pie that allows us to more properly diagnose them. So I vote if they have acute organ dysfunction, and I vote a lactate over 4 as acute organ dysfunction, they do go to ICU without a central line just for a day or 2, just for that extensive fluid responsiveness. And if the patients are misdiagnosed, for instance, for me, I look at the patients that the rapid response nurses send to ICU. I actually review all those cases, and I look to the ED to see if they have a working diagnosis of sepsis. And I look, do they get bands, do they get a PCT, and do they have a lactate? Because those 3 things together, for me, are the holy grail. If they have 30% bands, they have a PCT of 5, and they have a lactate of 4, it is very clear, even if they look like a CHF patient or a stroke patient or a PE patient, because so often they are called code strokes sometimes when they first come into the ED because they're obtunded. And so it does help to clarify that diagnosis. But I like the bands, lactate, and PCT combo, the manual differential.